resilience series. I'm wondering maybe if you could move to the next slide, and possibly even the next slide. So this is the 6 in our resilience series, which we co-host with colleagues from RCGP Scotland, and RCGP is represented on this webinar series by Scott Jameson, who's their Executive Officer for Quality. And we also co-host this series with Scottish Government Primary Care Division, and then many of you will know Michelle Watt, who is representing Scottish Government Primary Care Division and our co-host within this WebEx series. Just to let you know, I've got a slide up just now with some housekeeping instructions on it. And it really is just so that we can allow as many people as possible to join the WebEx. We're looking for you to turn your cameras off and also your volume off. And if you wanted to participate, and we really do encourage you to participate, is to put your comments within the chat box. We're looking for any questions or any comments that you may have. If you could pop those within the chat box. If you can keep your cameras and your volume off, that would be great, just to turn your mics off, because it does create a wee bit of an echo, which would be fantastic. Can you move to the next slide, please, Great. I think a number of you will have seen along the top, it does say this webinar is being recorded, and we are recording this so that we can share it with those who've been unable to join us. And that's partly because we have been oversubscribed for this webinar. We're at the maximum numbers of attendance, which is 250. So we are recording it, and we will share the link with those who were unable to attend. We'll also share the link with all of you following this webinar, so you can, if you wish, to re-listen to it at your leisure. And obviously we will share with you all of the links to the resources that are discussed throughout the webinar. We've an absolute packed schedule for this next hour. If we can move to the next slide, I'll quickly get us into the speakers. I just wanted to let you know that we are listening to you. For those of you who've been with us at previous webinars, you will know that we were using BT WebEx as the platform. You're having to dial in on your phone and also come in on your computer to see the presentation, which seemed so old school in this new virtual way of working for many of us. And so we have moved, we've done one test of change. We have moved to MS Teams, and that has proved one or two challenges for us, which is particularly why we're looking to ensure people keep their microphones on mute, so we've not got the feedback. The challenge really has been, though, around about the numbers. So we were limited with 250. We recognise that we do now need to, as our next test of change, go to MS Teams Live, because we can have a lot more people join our webinars. So we will look to do that in our next webinar, which we will hopefully host in around May time. I think now, though, without further ado, if I move to the next slide, and we can get into the discussion and the aims of today's webinar. And our overall webinar series is to really spend that time to reflect and to learn from our responses to COVID-19. And there has been so much learned in relation to anticipatory care planning and good conversations. And so we want to explore some of those changes have been made and what we want to learn from those changes, and how we begin to embed some of those changes as we move forward. And so today we are focusing on what matters to you in multidisciplinary care planning. And to introduce the first session, I am going to hand over to Michelle.
Hello everybody, it's really lovely to be back, and welcome to the latest webinar in our resilience series. It's absolutely great to see so many old and new names popping up on the screen, and whilst there's no doubt that video conference has really opened things up for us over this past year, and shared learning's been great, I really do still miss that coffee and blether and shall we head for a drink afterwards. And I just really hope that soon we'll be able to do that, as well as build on the learning we've had from our webinars. So here's hoping. So the pandemic certainly has been and still is a bit of a roller coaster, and many times it's felt like there's been, you know, a real kind of nowhere to get off and just get a bit of a break. But one of the things that has really helped me over this past year is to have a bit of a plan. You know, to know what the big picture is looking like as much as we can, and it really helps us to see how we can play our part in it. And I think that was really exemplified to me. I've been doing some volunteer vaccination clinics, and you know, to a person, every member of staff have said how much they enjoy doing it, how much they have really enjoyed seeing people again, sitting down, talking to them about their vaccine, planning and what it's all about, and having that, you know, kind of human interaction and exchange of information and shared knowledge and learning. And you know, that's as much of an anticipatory care plan conversation, I guess, as many other things. And you know, it's something that you know, we value incredibly. And I think that for me, that's at the heart of care planning conversations. That real buzz you get as a clinician, you know, when you can really walk alongside somebody on their journey, sharing your knowledge and expertise, but finding out really, you know, how their condition and how their learned experiences is affecting them, and really developing that relationship and working together to create a plan together. This is nothing new, and it's been at the heart of a realistic medicine approach for at least the last 5 years. And I hope that you all, a bit like me, have yet to meet anyone who disagrees with the realistic medicine principles. And if anything, they've been reinforced by COVID and probably perhaps strengthened. Hopefully we'll get it up on the chat bar, but for any of you who have not had a chance to read this year's CMO annual report, or dip in to the video that was recorded, I would heartily encourage you, because realistic medicine, care planning conversations and shared decision making is at the heart of it. They say that knowledge is power, and sharing that knowledge creates a balance of power. And as we hear from today's speakers, I'd like you all to think about how that applies to the people that you see every day in all the different circumstances that you do. We've got packed agenda, as Jill says, and firstly we're going to hear from Sean Mayer about really what matters to him, and then we're going to be followed on by Jan Beattie, my AHP professional advisor colleague. She and I work alongside each other at Scottish Government. And, you know, I always leave a conversation with Jan having learned something, and every time it reinforces to me how good it is to work as part of a multidisciplinary team where we can share knowledge, we can learn together, we can you really understand what it's like from our professional perspectives, but also just work together as a team. And that's the most important thing, is that feeling like we're all in this together. And how can we take that feeling and really expand it into the conversations that we have with our patients in a shared decision-making way. So that's what we're going to explore today, and I'd really encourage you to keep the chat box going, and we're going to hear from our first two speakers, and then we're going to have some conversations backwards and forwards. And so without further ado, I'm going to hand over to Sean.
Thanks, Michelle. Just checking in that you can hear me. Just give me a nod or a shout if you can hear me. Just put my headset on to keep out any background noise.
We can hear you good, Sean.
Good, thank you, lovely. So what I'm going to talk to you about, good afternoon, everyone. My name's Sean Mayer. I work with the person-centred team in the Scottish Government, and as a professional advisor, clinical advisor. My background is in nursing. I worked for 20 plus years or so, mainly as a senior charge nurse. And for the last 10 years now, I've been working in the sort of improvement and education roles in Scotland at a national level. So what my job this afternoon to do is just to refresh and reintroduce and maybe explore just very briefly a little bit about what is it about this what matters to you approach. What do we mean by what matters to you? Because there's a risk, I suppose, in some ways it can just be viewed as being, well, it's like motherhood and apple pie. What does it actually mean? It's a nice to do, but there's more important things we have to focus on. So I want to just perhaps dispel some of those myths and refocus in on the heart of what it is that this what matters to you approach brings to our work as healthcare professionals. So I like to, if we could have the next slide, please. I like to think of it as a compass. rarely is what matters to you the right framing of the question. It's more of an ethos or a phrase which reminds us to ask the question, whose needs are we meeting here? What are the things that are really important for this person in front of us? We have amazing information these days about population level, a population level about what works for 1,000 people if you give them this medicine versus that medicine, or that treatment versus this treatment. But we need to know, when we ask the question, what matters to you, or its equivalent, what's right for this person that's in front of me right now. And I think that what matters to you is a kind of an archetype, perhaps, as well, symbolic of the shift that's required in our health and care services to ensure that they're fit for purpose in the 21st century. So I'd like to start just by very briefly listening to 60 seconds of a story. It's a story from a young woman who has rheumatoid arthritis, and it highlights some key points which I think illustrate partly the problem that we have, but also the benefit that's to be gained from the what matters to you approach. It's an old story, so don't focus on the clinical details, but listen to the relational elements of the story and the impact that they have or had on the care that this person received. So if we could play the video clip. I'm not hearing sound. I don't know if anyone else is.
No sound, Sean.
So it might just be the sound, share sound tab on the screen share option. If not, it's not. We'll give it 10 or 15 seconds to see if we can get that sorted. If not, we'll just move on because it's not critical to the. This is where we do a reshare just to see if we get to work when we share again. If not, we will be able to move.
And I went in because they wanted to sort out the methotrexate problem, because they said you can't come off it because we don't have anything else to give you. And I said, well, I'm not taking it anymore, because it went on for about a year, the sickness thing, and nobody really cared. I mean, I cared, my parents cared, but the doctors, they weren't really too bothered. They said, if you're not on it, then you're not going to be healthy enough. And I didn't care. I didn't care if I couldn't do anything. I just didn't want to be sick anymore. So I went in, and various different doctors came to talk to me because I was under. She has a huge team, and they all came to talk to me, all of them, and then she came as well, so, the big top dog, and she spoke to me, and I said, no, I'm not taking it. You can't make me take it, because I don't care if I'm under 16. I'm not going to take it. And I just said no, and they said, well, we'll give you anti-sickness tablets, and I had tried those. They didn't do anything. I said, well, they don't work, so I'm not taking it. So they eventually they listened to me.
That's great. Thanks. So just leave the slides there. That's great. Good. So thanks for getting that sorted. So just listening to that story, asking the question of ourselves as we listen to her speak, what were the things that mattered to her? Was she heard? How long was it before she was really listened to? So she was listened to, but the shared decision-making process in this case was about helping the patient, Sarah in this case, to share the doctor's decision or the care team's decision about what they thought was best for her, rather than really listening to her and working with her to find the best way forward. So this is a very vocal, interested, engaged patient. How many other patients out there who don't even get close to this point in terms of the interactions and relationships and being heard in terms of what matters to them? So I think about then, as we're thinking about multidisciplinary care, teamwork and planning, what was the impact of not listening properly for that year in terms of the team's focus and activity on the care of this one individual? What was the impact on the quality of life for Sarah and her family? So we can see that failure, if you like, to really focus on what matters to the person that's in front of you can have a significant impact, A, on wasted activity in the team, because what we're doing isn't adding value, isn't helping the person really, and B, a big impact on the quality of life for the individual who's receiving care and support. So next, if we could move to the next slide. So that was just a kind of, it's a really, I think that's a nice little snippet of a story which just illustrates perhaps where we've got some work to do still in terms of really listening and thinking about shared decision making, not as I'm going to help you share my decision about what we think is right for you, but much more than that, much more of a collaboration that Michelle talked about, coming alongside someone and supporting and helping them to live a life that's right for them and get the help that they need to help them live that life. So a couple of points before I shut up. When we think about the other point, I think that's important to make is there's a continuum here with person-centered care. You know, there's the kind of more acute end of the scale where the focus is on fix me, and what the healthcare system used to be like, I suppose, from its foundation was mostly about fix me. We've much more now moved to the other end of this continuum on the screen here, where we're at the help me end. We've got people living for long periods of time with multiple conditions and trying to live well with those conditions. And so the what matters to you question will look different necessarily in these different at these different points on the continuum, and a couple of suggestions on the screen there. So that's the one thing. Think about person-centered care as a continuum. It's not like there's a magic bullet question that we can ask everyone that gets to the heart of the matter. We've got to be thoughtful about who's in front of us, what's the context, what do we know of that person. Next slide. And this is another helpful, if you like, visualization of what it is we're talking about here. This is taken from a publication called Intelligent Kindness, which if you haven't seen it already, I'm sure some of you will have done. It's a really helpful diagnostic on the current state of the system and where we need to go, and perhaps some ideas about what we can do to get to where we need to be in terms of having health and care services which are performing at a better level or a higher level than they are now. So this helps us to dig a bit deeper, and essentially the heart of their diagnostic is that we've lost our attentiveness and our ability to attune with the people that we're providing care for. We've industrialized healthcare, and there's been some benefits from that, but also what we've lost along the way, or what gets much more difficult at least along the way, is those moments where we reliably pause and we are attentive. You know, so every person, we make sure there's designed into our care processes an opportunity to be attentive and to become attuned to each individual that the system interacts with. So that's worth digging into a bit more deeply if you're interested. And then the next slide, just before I finish, this is the last point really. So the impact, I guess what I'm saying, of the What Matters to You approach for you as healthcare professionals working together in multidisciplinary teams is, number one, it fundamentally builds trust. And as that person-centered circle showed us there, trust is the foundation of a good therapeutic relationship, which leads to better outcomes for individuals. And the second point is that it helps us to understand what is it that we really need to do. What are the things that really matter that we need to do? And that helps to strip out the failure demand. The things that we perhaps like doing might mean giving up some cherished practices or ways of working, but it helps us to focus in on what we really need to do, and thereby also helps us to understand what we no longer need to do. So I'll stop talking there.
Brilliant. Thank you, Sean. Some really interesting things in the chat bar, and we'll come back to those. I'm scribbling away. And now a very warm welcome to Jan.
Thanks, Michelle. Hi, everybody. Really nice to be here. Already, I'm thinking, Sean's got lots of my brain thinking about lots of different things, and I'm scribbling away notes as well. So we'd love to hear about you now, and also after the webinar, if possible, if we have any thoughts. So I work along Michelle, as she said, in the Primary Care Directorate. I'm an allied health professional advisor, but I also tend to take a view for the multidisciplinary team and have a focus on non-medical prescribing as well. So today I really wanted to try and explore a little bit more about this expanding MDT we have in primary care, about how we can really maximise that workforce and think about it. Because there's great value in situations like this, learning together, in building understanding and building our relationships and everything. So my first slide, please. So very much as we look at the expanding MDT and building it, we're really trying to focus on the knowledge, skills, behaviours and experiences of the clinicians in the team and the wider team, rather than professional titles. Because what we're really trying to do is focus on what the best outcomes for a person are, and as we know, everybody's going to be different situations, so their care plan is going to have to be tailored and individualised to them. So how can we include them and their families, and it's that relationship building stuff and maximising that. Next slide, please. So our healthcare team, and I appreciate fully that there's a whole host of people who are involved, wider than just the healthcare team, that are involved in support, but we're thinking about these conversations that we can have in planning. So these are just a few of the people, and there'll be some of the different professions that we're seeing regularly around general practice and in primary care, and others less so. And I was actually and as I said earlier, I'm very clear that we've got social care, we've got lots of voluntary organisations, a local community, we've got different practice staff. I mean, we've got 14 different health professions that in allied health, and there's a range of different nurses. But when I looked at the ones I'd popped up there, because these are the ones we're seeing most common at the moment, although things will change in the future. And one of the things I was saying to Michelle, actually, they're all actually, apart from occupational therapists, are able to be prescribers. And are we really, so having that knowledge about your team member and knowing what the knowledge, skills, behaviour, experiences are really probably quite a good thing to do and to think about that. And obviously the teams will look different from local context. I suppose it made me think it's really quite important to get to know who's in your team and know what those knowledge, skills and behaviours they have. You may have, for example, a physiotherapist who is not a prescriber, but if that's important to the local context, they could become an independent prescriber, and dietitians are a supplementary prescriber. The other aspect I was reflecting upon is we've historically tended to think about these conversations towards end of life, or older people, and actually, we all need to have almost a care plan in place. If we've got any long-term condition, or even if for local circumstances require, what would I do if I broke my wrist? How would I get into work? All that kind of stuff. We tend to do that anyway, and some of this wider team are probably in a good place to have those initial conversations. So I suppose, again, just moving on to the next slide, please. It's not just like doing these reactive conversations. Who can is a good place to, sometimes it's to start the conversation, someone else to maybe continue it, and it might also be someone different again to follow up. And I was struck with the fact we tend to focus a lot from an MDT perspective, that there's, it's our advanced practitioners and they have a really vital role in these teams, but we do have a skill mix in our MDTs, and that skill mix is really, really important, both for succession planning, but also so we can maximise the staff the most. So I suppose my question is, how can we really maximise all the team at all different levels? And I've just popped up there, I'm not going to read it to you. This is Ness's levels of competence and skills. They don't translate across directly to bandings, the agenda for change bandings, but there's a similarity to there. So all the nursing and allied health professionals are autonomous practitioners when they qualify, so that will have experience in having conversations. And it's how do we come alongside people? Who's got the best relationship? It may well be your band 5 nurse or your GPN who has that best relationship and is best to start that conversation. And then, which I noticed in the chat earlier, one of our challenges, how do we feed that in? How do we make sure all that information is collated together for the next person to continue that conversation if it's appropriate? So our record keeping is certainly something for consideration, I think, going forward. And my last slide. So on that note, there are a number of different pieces of work, because the other thing is what we think of what was the role of our GPN or our dietitian or even a GP. We've seen there's been massive changes, and professionals are developing the whole time. One often quote is, we think about our podiatry colleagues. Not so long ago, it was only advanced practitioner podiatrists who were able to prescribe, but nearly all it's band 6s that are tending to prescribe now, and all band 5s come out using POMs. And that's just how the profession's developed. And we could probably say that the same for the whole lot of our different members of the team. You know, our GPs are really focusing on that expert medical generalist role. So what does that mean, and how do we include the rest of the team? So I think just to conclude is that let's not just look at the now, let's also look to the future. What's the future possibilities within that team? What's the future of the people are requiring, and that what matters to them, and how can we adapt to come alongside people to make sure we get really good care planning for people going forward, and not leave it as a reactive thing, actually help people to do that care planning now and keep reviewing it and move it for the future. So that's my questions for you I'm posing today, is how can we really maximise all that team? Thanks, Michelle.
Brilliant. Thank you, Jan, and thank you, Sean. Some really interesting and thought-provoking kind of questions and slides there. And it really struck me there's a couple of themes emerging here, and threading through it all seems to be so much that this is about culture and behaviour. It's absolutely not about sticking a load of information on a few bits of paper that gather dust on a shelf. And I think your comments up the side have been really illustrative of that. So Faye from Fife and Lorna, you have some interesting comments, thinking outside the kind of patient doctor clinician relationship around interviewees, and actually when you ask people in general what matters to them, some of the themes that come out are around enjoying their work, being valued, about having a work-life balance, being well. Gosh, that's just so fundamental to everything that we are wanting to do. And I think Ed Russell-Smith, you raised some really interesting questions about access versus quality. And I think what's coming out loud and clear from your comments and actually from the slides is the importance of making sure that there's actually time to be human beings together and not just human doings, rushing about trying to do process, because actually working as part of that multidisciplinary team, shared understanding between professionals is as much an important part of care planning and shared decision making as it is with the clinician patient relationship. And I think, Ed, you also raise an interesting point about that internal locus of control. And speaking from my own perspective as a GP, sometimes you just get off on the wrong foot, don't you, with a consultation, and what can seem stroppy to some can be really challenging. And I think really picking up on many of your comments down the side, as a healthcare workforce, we are knackered. It's been a really, really difficult kind of journey for us all, and it's back to Faye's point that we don't feel valued or feel that we've got a work-life balance, or we feel well, how can we give of our best in the workplace for others? And I think that's really, really important. So I think we often say first put on your own safety jacket, and I think we also need to think about how we can support the importance of having these conversations together as well. The other thing that I think came out loud and clear from you, Jan, was the importance that that care planning is for any age, and really thinking collectively about what matters for the future as well. So some really interesting things that I'm sure I'll certainly like to go away and think about for a few days and cogitate for a little bit. But the other thing that came out loud and clear for me is before we get to shared decision making, let's have the shared understanding first. So moving on to the second part of our conversation now, I'm going to welcome Scott. I hope he's managed to join us. He's probably been a busy GP in surgery this morning, and we're going to move on to the next part of today's session. So over to you, Scott.
Thank you so much, Michelle. Excuse my tired colleagues. I'm just doing a minor surgery list this today. And so thank you, Michelle, for that first half. That was excellent. And thank you to our previous speakers for Sean and Jana. And I think it really nicely set out the landscape, didn't it, of where we're at and why it matters. And I don't think we would have such a large number of participants today if we didn't all agree that this is critical to get right. And there are some opportunities, there's some developments, I should say, coming forth that I am aware that are being worked upon nationally to try and bring this important conversation crystallize a little bit better, because we're a small enough country where we could make this a lot more joined up and a lot more workable for every part of our healthcare system. And I warmly welcome that. And so we all agree that it's important, and then it's how do we do it. But the point in today's session, in this half, is, well, what do we do in the interim? Because it still needs done until there's a more unified system that could really help us. And we're almost there, but we're not quite. More improvements to come, and it's really great to be able to welcome some fantastic speakers this afternoon to cover three more in-depth aspects in practical terms. First of all, we've got my colleague Paul Bond, who a widely respected GP from Dollar, the National Clinical Lead for Palliative Care, a Healthcare Improvement Scotland professional advisor for Scottish Government. I think you might still be doing that, Paul, I can't remember. But Paul's a extremely well-known GP for his interest in palliative care. We move straight after Paul on to Raymond Rose, who I don't know Raymond. It's nice to meet you. Raymond, I think, was in the Scottish Ambulance Service for 4 years, and now works, I think, a bit part-time ambulance liaison. I've done a lot of work with Scottish Ambulance Service up in Tayside. I've been out in the vehicles. I go out with the advanced paramedic practitioners. Anticipatory care planning is critical for what they do, and I'm sure he'll articulate that really well and far better than I can. And lastly, straight after Raymond, move on to my colleague Jude Marshall, who's a GP across in Glasgow, who will be talking to us about care homes and anticipatory care planning. Absolutely critical. Paul, over to you.
Okay, thanks, Scott. Hello, everyone. So I'm going to explain why anticipatory care planning is important, why having a key information summary leads to better outcomes, and why I believe that there's a need for practices to examine their process for keeping these up to date. So anticipatory care planning is a person-centered thinking ahead philosophy based around what matters to you conversations. It provides the opportunity to consider and plan for future changes in health. Next slide, please. The best way to share ACP information within healthcare remains the key information summary. And we know that having a key information summary makes a difference. Last year, research published in the British Journal of General Practice showed that people who had a KISS were 3.7 times more likely to spend their last days of life in their preferred place of care. Next slide, please. And this is why GP practices were asked to add information to the KISS at the start of the pandemic. And what an amazing response. Millions of key information summaries were uploaded. So last February, 5% of the Scottish population had a KISS. Now we have 33% of our population with something written in the key information summary. Now, most of these are what I would call COVID kisses, with basic information about current medical conditions, rather than being true anticipatory care plans. And this causes us a challenge. How do we review and keep the useful special notes up to date when the average Scottish GP practice will now have 2,000 people with the key information summary? Next slide. So I'm going to suggest that practices and primary care teams adopt a 4-step process, which is applicable for both anticipatory care planning and for reviewing the key information summary. And the 4 steps are preparation and planning, meaningful conversations, documentation and sharing, and then regular review. And the rest of this presentation will go through these 4 steps. So next slide, please. Preparation and planning involves identifying who you'll be having an ACP conversation with, and then preparing yourself and the person for that conversation. It will require a whole team approach involving everyone in your extended multidisciplinary team, the people that Jan had highlighted in her slide. Consider how to engage with your team and explore how they can all access and update the KISS, either directly or indirectly. Preparation also involves preparing yourself for the conversation by finding out as much as you can about the person before you meet them. You know, what's their current state of health? What realistic options are there for future care and treatment? You must also prepare the person that you're going to be speaking with. Provide them with information about anticipatory care planning. Check if there's someone else who should be involved in these discussions, for example, a power of attorney. Next slide, please. The conversations between the health or care professional and the individual and those that are important to them are at the heart of anticipatory care planning. And a really good framework for these conversations is REDMAP. R stands for ready and suggests how you might open the conversation. E for expectation is where you should explore the person's understanding of their health. D for diagnosis allows the health professional to explain any health conditions and options for treatment. M for matters is the important what matters to you conversation, which Sean has explained. A for actions will explore what can and cannot be done, and P is about agreeing a plan that's right for the person. Next slide, please. Once a plan has been agreed, it's important that it's recorded and shared with all those that need to see it. And listed on this slide are a number of tools that support the gathering and sharing of this information. However, it's important that these resources and tools do not become the focus of the interaction. The conversation with the individual comes first, and then these tools, forms, and documents are secondary. Next slide, please. The best way to record aspects of an anticipatory care planning at the moment is the key information summary. However, not all primary care professionals can access this. And so HIS and NEST Digital have just launched an essential ACP online tool, which is a web-based way to document this information. It can be saved as a PDF, and a copy is on this slide, and it can be emailed to the patient in the GP practice. And aspects can be copied and pasted into KISS. The next slide, please. The final step is regular review. And this is where I think we need to take a pragmatic approach to reviewing the thousands of key information summaries within each GP practice. So guidance will be sent out to all GP practices next week that suggests 2 different approaches that you might want to take. Next slide, please. The first approach or option is to identify people within specific categories. For example, people living within a care home or those with significant mental health conditions, and then to prioritise this group. The second approach on the right involves focusing on those KISSes that already have a detailed special note, rather than the more basic COVID KISSes. Next slide. For the first option, we suggest that the admin team, and that's the upper part of this flow chart, does the initial search for people within the group that you're focusing on. So for instance, does a search for people with, on your mental health register. Then the bottom part, the appropriate clinical person should look to see if there's a KISS and whether it's up to date. If it is up to date, then we recommend that future reviews are linked to other planned work, such as chronic disease management reviews. The next slide. The second option that I suggested involves the admin team again searching for KISSes with a special note. And if the KISS is a basic COVID KISS without a special note, then this might not be a priority for now, and the review dates could be changed. Those with special notes can be sent to the appropriate clinical member of staff. If the special note looks up to date, then again it's not a priority and the review dates can be changed. This will leave a much smaller number to focus those meaningful, what matters to you discussions with. Next slide. So in summary, anticipatory care planning is important. It requires a whole practice and multidisciplinary team approach, and it involves preparation and planning, meaningful conversations, documentation and sharing, and regular review. And my last slide, please. So we will add some of the links to these resources that I've mentioned in the chat box. Please get in touch with me if you'd like to discuss any of this, and my contact details are at the bottom of this slide. Thank you.
Cheers, Paul. That's much appreciated. We'll just move straight on, if that's okay, to our next speaker.
Good afternoon, everybody. My name is Raymond Rose. I'm an ambulance liaison officer, as Scott has described. I've been around a fair amount of time, and my present focus is working in the west of Scotland, dealing with mainly end-of-life patients and palliative patients. And what I want to do today is give you some practical examples based on the theory that Paul's just outlined of what a difference having an ACP makes to ambulance crews when they attend a patient. Next slide, please. Now, most people expect when they phone for an ambulance, a very large box turns up with 2 people in it. In fact, for the highest degree of importance, you'll get a single manned vehicle like this. This is a paramedic response unit, sometimes known down south as a rapid response vehicle. And very often, these people are paramedics, quite often with advanced skills, who can make decisions on scene that make sure that we don't require to send a double manned vehicle and perhaps keep the patient at home. And for them to be able to do that and make that assessment on scene, they need that information in front of them to make an informed decision, along with the patient and the relatives. Next slide, please. Whilst I've just said that I mainly focus on end-of-life and palliative care patients, on discussing this with my colleagues, they all reminded me we need to think about other types of users, particularly high-intensity users, with a particular focus on patients who have mental health crisis or mental health issues. High-intensity users aren't necessarily people who are abusing the system. There are people with chronic chronic illness problems who require to access the system. And it's important to pick up on them and make sure that they're pointed in the right direction, and it tends to reduce the amount of calls that we get. Next slide, please. So these are a couple of examples of what happens when an ACP or KISS isn't accessible. And at the moment, we do have some technical problems with accessing these, and sometimes we have to look for paper copies. But I want you to focus on the highlighted words here. So a cardiac arrest, where they were in 10 to 12 minutes into an arrest before they found out that the patient was a palliative care patient and wasn't for resuscitation. It had all been agreed. And for anybody who's attended a cardiac arrest out of hospital, they know how traumatic this is, both for the attending crews and for the relatives to watch this going on, and you're 10 to 12 minutes into it when you have to stop when you realise that the patient herself didn't require it. The second example is a palliative cancer patient who wanted access to palliative care, just in case medications, but the crew on scene took several hours before that could be sorted out and the correct information was found. So that's 3 to 4 hours with a crew tied up with the one patient, when if the information had been there, we could have dealt with that patient much more quickly and much more satisfactorily. Next slide, please. These are the examples of what happens when an ACP is accessible, particularly in a nursing home. There was an ACP in place in this example. The crew were in and out within an hour, and they found that much more satisfying for them and much more satisfying for the patient. The next example is an example of a terminally ill patient who was actually well known to us. He was very reluctant to attend the emergency department, as he himself had said he'd had enough of hospitals. And he'd refused to go to hospital, but there was an ACP in the house which outlined all this, and the paramedic on scene managed to get the treatment for him to stay at home, and he stayed at home and he died at home, which was the ideal outcome. So that's just very quick examples of the difference it makes of having that information on scene and also back in the control room. People I've noticed have been talking about access to clinical portal. We have very, very limited access to clinical portal and not out on the road. So if we're requiring information from clinical portal, it's only within Glasgow at the moment we get it, and that requires a phone call back. So I hope I've managed to illustrate exactly the difference an ACP makes in practical purposes for ambulance crews, and I'd like to now hand over to Jude Marshall. Thank you.
Thanks, Raymond. Hi, I'm Jude Marshall, and thank you so much for asking me to talk about ACP in care homes today. There's so much to say in so little time. I'm a GP in Glasgow, and once I completed my training, I worked in the Marie Curie Hospice. Once I left there, our practice took on the care of patients in local nursing homes. And I realised as soon as I started working in the care homes how important conversations about what matters to the patient and their future care were, and what impact they had. What I'd learned about these conversations at working in the hospice, conversations that were routinely had often been lacking in my hospital jobs and in care homes, but I'm delighted that things were moving on. The first realistic medicine report was released just as I started care home work, and the principles of sharing information honestly with patients and allowing them and their loved ones to be part of shared decision making and reducing harm through over-investigation and unwanted admissions in my case really stuck with me. Next slide, please. ACPs are evolving conversations. In our care homes, it begins early at registration when the patient and the family are invited to be part of the conversation, and this is built on over regular meetings that follow. And all staff members are on board with ACP, and that's vital for us. I think different to other settings, patients' families don't feel as worried about you bringing this up, that if you talk about deteriorating and dying, it means it's going to happen sooner. And by far the majority of the time, patients and their families are grateful to have the chance to speak about what matters to them and their hopes for the future. Doing ACP routinely, as care homes do, gives an opportunity for sensitive discussions to take place when someone's not acutely unwell, when things are calm and people can think through their decisions. I find it helps to start with asking what's been happening over the last year to bring them into the care home. That lets the patient and their family tell you their story and their take on how things are now. And it allows us as healthcare professionals to give any information from our knowledge and experience on what may happen from now specific to their illness. I also use the Lothian ACP tool to talk through possible scenarios, including collapse, severe infection, and increasing frailty. ACP conversations are also great opportunities to address any expectations or misunderstandings about health. It's also a time to talk about what matters to the patient, which might be less clinical. As well as hearing what the patient needs and what we can expect, we should also be promoting what we can do in care homes. ACPs give us time to plan for types of care or equipment needed, and the care and compassion that's provided by care staff in the care home at the end of life is invaluable and much appreciated by patients and their families when it's done well. And this deep interest that the nurses and the carers and GPs have in what matters to the patient and their family really helps to build trust and open relationships. And then when change occurs, it can be communicated in an honest way and it's calmly managed, and it reduces stress for all involved. The tools that care homes use are all different. Each provider has their own system. But I feel at the moment it's the conversation and perhaps not the specific tool nor who has the conversation that matters. And what's imperative is really that we share this information, as Raymond was saying, so that GPs have it documented, as do the care home. I think in order to reduce unnecessary or unwanted admissions, we maybe need to look and reflect on what's happening. Firstly, if an ACP is not done in the first place, these important conversations are postponed and then a crisis happens and the time for calm planning and discussion is gone. But a clear ACP that's been discussed with the family and the patient well, which is recorded in the patient's notes and GP systems with health and care professionals who are experienced and know their patient, should prevent unwanted admissions. If the ACP conversation initially has covered specific scenarios, as the tool I use does, then it's also covered most situations that may arise. I think we all need to reflect on how comfortable we feel in supporting people at the end of life in care homes. We need to all be on board and similarly minded. I know from my experience some of the staff worry that their registration will be at risk. And I think that part of practice development in care homes should be reassuring staff about that, educating and empowering them on recognising change and what that means for the patient and what actions to take to prepare once the change is noted. I think we also need to remind those working in care homes, as well as GPs and nurses and the families, about what a patient experience of hospital admission is, the middle of the night ambulance, emergency department, repeated ward changes, as well as many changing staff. What impact will that have on their patient, and what do they think are the benefits of the patient going into a hospital? If there's been admissions, then reflecting with the care staff involved about what's happened, because they must have felt that they or the care home couldn't meet the patient's needs. And I think there's learning in that situation for all of us. So these are just some of my reflections on care homes and ACP. I hope that was helpful, and I'll pass you back to Scott now.
Thank you so much there, Jude, and thank you for that very more practical kind of look at the three parts of the ACP from three different perspectives, and some discussions extremely vibrant within the chat, and maybe just tease a couple of them out. The first one, I wonder whether, Paul, if you're still around, whether you want to comment. It's a hot topic. Opt-out, like we should do with, you can, it's opt-in for, it's opt-out for organ transplant. Should it be opt-out for your ACP, or for your KISS being shared?
So, as most people know, normally to create a key information summary, you need to obtain explicit consent. During the COVID-19 pandemic, GP practices were allowed to create a key information summary without consent. I think it's still best practice to definitely get consent, but I think there is a moral argument to say that it's more harmful not to share clinical information, and that the public would expect us to do that. And so I think if it's not possible or not practicable to obtain consent, then my personal feeling is that in the future I would like to see GPs and GP practices supported to still be able to produce a KISS. At the moment, we're still in the COVID pandemic, and so at the moment, we have been given dispensation to create a KISS without consent. But I know that there's a group looking at what happens in the future.
Yep, Paul, as you know, from my outdoors perspective, I wholeheartedly agree. It's a great saviour to be able to see that, and absolutely. Michelle has mentioned a national dialogue, and I think the national conversations were picked up earlier as well about that difference between ACP and DNA CPR, and they're just not a synonymous being at all. And I'm wondering, maybe yourself, Jude, what you're thinking in these conversations, maybe within the care home settings. How do we make sure that the people don't get mixed up, that by writing or declaring an ACP, that you're not saying that we're giving up the ghost here? Because I think that's always been the concern about these conversations.
Yeah, I think 100%, Scott. I think people don't understand in the wider population what DNA CPR means. And for me, unfortunately, I've come across care situations where people will say, well, they've got an ACP, they've got a DNA CPR. And that's the first thing I say. A DNA CPR is one very small part of an ACP for someone who's in a care home. There's so much more to it. So yeah, I think a little bit more education. There's a lot of change possibly coming with, the DNA CPR becoming a bit more like respect, or respect overtaking DNA CPR. And I think almost a form for me that doesn't say do not attempt. I think that's quite an aggressive red form, that when families see that, they worry that it's a type of treatment that we're holding back from their relative and don't understand why we're holding it back. And really in the care home, CPR is not appropriate for the vast majority of patients, in my opinion, but it all needs to be considered on an individual basis and explained to families. And that's been one of the things I've done in the care home, is try and explain the process of DNA CPR and how to discuss it with the care staff so that they understand what we mean and they can pass it on to the families.
Yeah, absolutely, and I think that it's one of the few national policies I do still refer to sometimes and still need to, and it's a quite old policy now. But there is a national Scottish resuscitation policy, I'm pretty sure, which oddly is normally sort of policy you might see at board level, but there is a national policy which is very clear about the CPR and what it's there for and what it's not. And forgive me for not knowing the link offhand, and somebody might be able to find it and post it in the chat, but very much it's a documentation, isn't it, that CPR form, about a conversation, and no more than that. It's there to document what's been discussed, but in itself is just a piece of paper like anything else. But it's a universally recognised piece of paper across Scotland, which has huge benefits as well. And another bit I was just going to pick up on the chat was with regards to there's this, we do try to keep ECP succinct, says my colleague Lorna Stewart in Fife there, and it's about that succinctness and ability to read it. And certainly reflecting as an out of hours GP, reading it on a tough book as we drive to a care home or to a patient late at night, trying to read ACPs and trying to make head or tail of them when it's dark and the car's moving and you're trying to get that. I may be just reflecting with colleagues here. How do we get everything into a format that is as accessible to myself in the car when it's moving and it's dark and it's poorly lit and the screen is not that massive, right through to something that adequately captures what's important to the person. And I think that's quite a challenge, but it's a challenge that we need to embrace. The other bits I was going to comment on was just the parts about the reviewing it and the responsibilities for that. I completely agree with GP colleagues that have raised it and others that the wider MDT absolutely should be a critical part of that. And it should be coming to a shared understanding that everybody signs up to, most importantly, driven by the patient, that we can all agree goes into the notes, and everybody has to be aware of it, but absolutely does not need to be universally done by the GP. I think the targeted approach is certainly probably where my practice is going to look at, and that's what we've always done for our care home patients. And look at that, Tom, well done, thank you. We've always started in that kind of way, so all my care home patients get that soon after they arrive. Nothing more from me, and thank you so much to our speakers for the second half and to all our speakers throughout, and particularly to Paul and to Raymond and to Jude there. It was a really excellent part to really crystallise this more practical part of the ACP. I'll hand back to Jill. Thank you so much.
Okay, yeah, thank you, Scott, and again, thank you to all of our speakers for sharing your insights, links to all of the resources, and also for challenging our thinking. I think there's been also lots of great commentary in the chat box, so thank you to all our participants for challenging our thinking. I was reflecting there as I was reading some of the comments. We always seem to be in that place where the technology always seems to be the hindrance in so many ways in and around some of the resolutions. I also, though, did like Sean's comments there around about demystifying some of the sort of service centred names that we give things to help with that public perception. So really useful conversations, and in relation to all of the links that were referred to throughout the discussion, we will summarise these and share everything that has been kind of alluded to throughout the discussion with you all following this webinar. Next slide, please. So future topics. This is quite a difficult slide to see. I don't know if you folks can see this. We did ask our previous participants, and a number of you will have been part of that group that were asked, what you would like to discuss at future topics. And coming through fairly strongly was around about primary care recovery, access to different types of consultations, so triage and looking at the face-to-face consultations, telephone consultations, and the use of technology, so looking at things like remote consultations such as Near Me and asynchronistic consultations. And so we were thinking perhaps if we look to focus the next topic on in and around those different types of consultations. There are a number of other big hitters there, a number of which we have previously addressed. If you wanted to maybe move to the next slide, please, just refresh. This is our 6th webinar. We've run 5 in the series. We've had 8 topics. You can see them listed there. So I think long-term conditions management is coming through and interface working, and we've had webinars on those, and we can reshare the links. It maybe is timely for us to revisit. Things are moving so rapidly, and the pace of change is phenomenal in this context. So it perhaps is time for us to revisit. We have been overwhelmed by the engagement that we've had within these webinars, and you can see there around about 2,000 attendees, and most of you are liking what we're discussing. So we will take that as a bit of a green light to continue in the vein that we have been, and we will come back out to you for a bit of feedback on this one. I think maybe into the next slide, please. And we will pop the evaluation survey link in the chat box. We will send that follow-up email with all of the links, etc., and the date for the next webinar. We are really mindful how busy you are, and I'm really mindful what Michelle said earlier around about we are all knackered, and we need to value each other, and so we will look to run this and ensure that this is at a pace that works for you, and mindful of where the service is and where you all are, and how we can facilitate in a way that is useful to you. I think that is it from me. I think the final slide is the link to our resources, and we will obviously send all of those also on to you. And just a final word for me to thank you all very much for joining us this afternoon, and have a good afternoon. Take care. Bye.